So good afternoon, everyone. Welcome to this webinar of the JoinHealth Spring Series on Value-Based Healthcare. And for those who are joining us for the first time, these webinars are a collaborative initiative of the Health Cluster Portugal and DIT Health, herein represented by Miguel Amador. And our aim is, with these webinars, is to create awareness in specific topics of interest in health, and also to promote networking with the speakers that are invited for the webinar. So thank you very much for attending. And today we have a webinar that is dedicated to a very hot and debated topic, which ends up bringing together many of the macro trends and some of the subjects that we have actually been hearing about also in this forum, namely the patient-centered view of health, the need to rethink the healthcare systems, envisioning a sustainable and value-driven models to improve outcomes and control costs. So to talk about these topics from different perspectives, we have in the agenda 3 notable speakers. We'll have Christina Ackerman, who will give an overview of the topic in the first part of this webinar. And then Ana Rita Londral from Value for Health Collab and João Bane e Costa, who will present 2 case studies of the institutions they represent. So thank you so much, the 3 of you, for accepting this invitation. Just a brief note before we move to the presentations, that after each presentation we'll have time for a quick discussion and for questions from the audience. So please use the Q&A box for asking questions to the speakers. And as usual, the presentation slides will be available upon your request at the end of the webinar. So if you want to have access to these presentations, please fill out the survey that we will send you after the webinar. And also the recordings of the session will be available on the YouTube channel of the Health Cluster Portugal. And now Miguel will do the honors of this webinar and introduce our first speaker. So Miguel, over to you. Thank you.
Thank you, Patricia. So with us, as Patricia already mentioned, we'll have Christina Ackerman. It's a pleasure to have her with us. Christina is a senior advisor for EIT Health and is the chair of EIT Health Value, high value care firm, an initiative that EIT Health is pursuing on this specific topic. But more important than actually what she's doing on EIT Health is what she knows and did in her past. Until 2018, she was the president of ICHOM, one of the main organizations pushing for the standardization of, let's say, outcomes. She's also a faculty in the University of Texas, Austin, on the medical school there. And on the past, she has been working for a long time in healthcare, being in front of the Swedish Medical Product Agency, and was also part of the members of the board of the European Medicine Agency. But picking here a little bit on this high value care, value-based healthcare topic, I think it's something that's concerned. Everyone agrees that it's needed, but I think what's important now to understand is what matters most moving forward. And it's with this that Christina bring us her presentation. So the floor to you, Christina.
Thank you very much, Patricia and Miguel, and thanks for the invitation. So I will try here to share my screen, and you have to let me know if this works okay. Seems like it should be there now.
All working, yes.
Perfect. Great. That's a good start, isn't it? So really good afternoon, everyone. And if there is anyone in another time zone, good morning or good evening, whatever. And thanks for the invitation. And I'm very excited to be with you all here today, and would like to start asking everyone in this webinar a question. How well do you know the health outcomes that matter most to the patients you intend to serve? do you know what matters most to them? Because that's important, because people seek solutions that improve their health outcomes. And to understand what matters most, which is the title of my presentation, that's essential to achieve high-value care and in the long run to achieve health. So if we think about this a bit more, there are studies showing that health outcomes are significantly underrepresented in available measures that we are mandated in healthcare to measure and report. And there was a study from the US show that, and I think this is quite similar across most countries, so it's not US specific, but this specific one showed that only a bit more than 10% of mandatory measures to be reported in healthcare are health outcomes. And of those 10%, only 15%, or approximately 15%, are reported by the patients themselves. So then you can ask, okay, 10% health outcome, that's not much, but does it matter who reports? And is it not enough to have the clinicians reporting the health outcomes? And I would say that the answer is no, it's not enough. And let's move to the next slide and take an example from the Swedish. I'm Swedish, my background is Swedish, so I take an example from the Swedish Cataract Registry. And an example which I am sure is very well known to Health Cluster Portugal, and as Health Cluster Portugal is a front runner in the field. And in this case, from the Swedish Cataract Registry, in a study of almost 10,000 patients, the vast majority, or in this case, 97.8% of those patients achieved improved vision on the test after treatment. But 7.4% of the individuals, they reported being worse off in their daily activities and worse off than they were before treatment. So then you can, of course, ask, how is this possible? Because we obviously have a good clinical outcome of this treatment, but still the patient didn't have a good quality of life. And the explanation to this is that it's the combination of understanding that is important, because the treatment had restored the long vision, and that is what's clinically reported. But when you combine that with the information from the patient, then you also added an information about what mattered most to patients. Like in this case, if you are older, you often maybe not use your long vision that much because you might be much at home, reading newspapers, doing handicraft, and that's near vision dependent activities. So having both the clinical and the patient reported health outcomes at hand, that lead us to making sure that what matters most to each individual is also possible to move towards and achieve. And that makes it possible for healthcare to constantly improve. Like in this case, you can improve the process, making sure that reading glasses, for example, are part of the process after treatment for cataract. But it could also lead to a much more informed discussion with the patient about what truly matters to them, about their daily activities, and how important the long vision is to them as an individual before the treatment is decided. So in combining the clinical and the patient-reported outcomes gets a much more holistic perspective and makes it much more possible to improve healthcare, to achieve what matters most, and to also involve the patients, of course, in shared decision-making, to really find what truly matters to each and everyone and reach these goals. So this is, of course, where we would like to go. But unfortunately, to keep the health outcomes that matter most to the patient at the center, and achieve what we were talking about in the beginning, the high value care and in the long run health, we still have a way to go. And here I'm referring on this slide to a report from OECD from 2017. And that report suggests that at least, I would say, 20% or one fifth of health spending could be channeled towards better use. And because the numbers here show that many patients are unnecessarily harmed at the point of care. And that's one piece where we do not compare and share with each other to improve healthcare. But it also points at the fact that many patients receive unnecessary care and care that makes no difference to their health outcomes, or that the same benefits could have been provided by using fewer resources. That's why it's important to measure, to understand what matters most, and to measure this clinically and patient-reported wise. And we know that there are issues globally of highly variable outcomes and harm that could have been prevented. Obviously, inappropriate care and unnecessary spending. And this is not one country or one continent. It's the same worldwide. And we might say that there are, and we know there are real differences in medical care and our payment approaches, but the problem in healthcare delivery has a deep common root cause in the failure to measure health outcomes. So that's why I, in this introduction, would like to strongly argue that it is key to put the focus on the patient and understand the unmet need or the unmet needs in patients. And patients with a certain medical condition, for example, hip and knee osteoarthritis or diabetes, or in a segment of the population, for example, older persons. So we need to ask what matters to you. And I have met many who say, oh, I'm already asking this. But when you start looking at it, like the study I was referring to earlier, that the health outcomes are quite low in percentage of what we actually measure as mandatory. And that's why I wanted to take the opportunity to also discuss with you what health outcomes actually are. And I'm starting to talk about what they aren't. Health outcomes are not structural metrics. It's not ticking a box that processes like protocols or guidelines are followed. And it's not indicators like scores or surgical margins. It is not experience of care asking a patient, how were we? But outcomes are the actual results of care. And that includes, as we have discussed, clinical measures such as survival rates and the complications during treatment. However, the outcomes that matter most to patients are often how care affects their capabilities and quality of life. And we therefore need to ask, how are you to fully cover all relevant health outcomes? So with this, I hope that if you do not already know the health outcomes that matter most to the patients you intend to serve, you will find it of value to involve patients to get to know these outcomes and also make sure of them being part of the reporting. Let me then show you a quick guide to help think through the different aspects to cover when defining the outcomes together with the patients, families, and carers. And if we start with episodic medical conditions like hip and knee osteoarthritis, I think that these three tiers are very helpful because they consist of the importance of survival, of course, but also how the journey to survival look like, the process of recovery. And as tier 3, to what type of life do you survive? So this is quite straightforward and very clear when we are talking about episodic medical conditions that has a starting point and an end point. But when living with a chronic condition, long-term survival is of course still highly relevant. But for these patients, healthcare is not an episode, and that with a start and an end. But it's a part of life. So in addition to understanding the journey and to how you are at the end of a condition, here you need to understand the capabilities and the life a person can live with a chronic condition. And in order to make that more detailed and a better understanding of it, there are two more categories that are important to consider besides capabilities here, and that's comfort and calm. And comfort is success in lessening the burden of disease, which is, for example, reducing physical pain or emotional anxiety, which in an episodic condition could be part of the journey to survival. But here is a part of daily life. And calm is the success in lessening the stress of living with this condition of treatment, for example, reduction of stress around hospital appointments that you have on a regular basis. So with these two slides, I hope that you see ways that it's not that complicated to start defining these outcomes and health outcomes that matter most to patients for both episodic and chronic conditions, or segments of patients like older people who often have several conditions at the same time, both episodic and chronic. And as Miguel also introduced in the beginning, between 2014 and 2018, I led ICHOM, which stands for the International Consortium for Health Outcome Measurement, and is a non-profit organization with a mission to catalyze the development of standard sets of outcomes for medical conditions in order to help understand what truly matters and standardize it in order to be able to also decrease the highly variable outcomes that we discussed before. And we used certain principles when developing a so-called standard set that, of course, first health outcomes were defined around a medical condition, not a specialty or a procedure. So it's about hip and knee osteoarthritis, for example. It's not about replacement of the hip. And this is one of the foundations for this. And the set was then defined to represent a minimum set focused on outcomes that matter most to patients, and to make sure that there is a well-rounded number of outcomes, that so it's not just pick one or two, but actually they cover the holistic perspective of each individual. So in order to make sure this, patients are directly involved in defining every set being developed, and patient-reported outcomes are also part of every set and include what we just have discussed, the functional status, the symptom burden, and health-related quality of life. And to ensure comparability of results between different groups, institutions, countries, etc., time points and sources of data collection clearly defined, and a minimum set of also initial condition and risk factors is included to facilitate meaningful comparison. And as an example of this attempt to create a global language for health outcomes, I would like to show you the standard set for breast cancer. where you find survival and disease control. That's between 10 and 12 on this in the circle. And this utility of care, which is about reoperation due to positive margins and acute complications to treatment, we find between 12 and 2. But most telling, I find that the majority of the outcomes, which are from 2 o'clock to 10 o'clock in this standard set, they are patient reported. And that is often what we saw at ICHOM, that when you brought healthcare professionals, patients, family carers together to discuss what truly mattered to the individual, and in those cases where the family and the carers are heavily involved, like dementia, Parkinson, etc. There was often a surprise by the healthcare professional what truly mattered to patients. Because as clinicians, we many times believe that we know what's important, but there is always a surprise in this understanding that, that's what really matters to individuals. And that's also very helpful in order to be able to have an informed discussion, move to a shared decision-making with patients, to really be able to understand from the clinical standpoint what matters most, and understand for each individual how that individual then can be advised and guided toward a treatment that with the highest probability will then lead them to these outcomes. So there are, now I've talked about ICHOM because I know ICHOM from my work there, but there are other initiatives. During my time at ICHOM, we also did and compared our work between ICHOM and other initiatives. This one, which I'm currently showing you as a slide, is a comparison between the ICHOM standard set for chronic kidney disease and the SONG initiative on the same condition. And when mapping these two, you might not see it in detail here, but when we did the mapping at the bottom here, you can see that there is a large, I would say, overlap. And you can find the SONG work and many more under the COMET initiative. So I have put also the website for the COMET initiative at the bottom of the slide. And the COMET initiative is an initiative that brings together people interested in the development and application of standardized set of outcomes. And they talk about them as core outcome sets, or COS. And these sets represent the minimum that should be measured and reported in all clinical trials of a specific condition. So they come to it from the clinical research perspective, while ICHOM works from the clinical care perspective. But as you can see, large overlaps, and these core outcome sets are also suitable for use in routine care, in clinical audit and research other than randomized trials. So I think this is important to see that there is work ongoing across the globe in this direction. So there is hopefully always a place to go and start looking for something once you decide to start measuring these health outcomes. So there are places to go and look if there are already ideas of what type of minimal set of health outcomes for a condition or a segment of patients there could be. So by measuring and improving patient health outcomes, the wasteful spending that I was talking about and we know exists, the wasteful spending on health, but not only the wasteful spending, but also the complexity and the disease progression that drive the need for more care will be reduced. And more resources will therefore be available for prevention. So focusing on outcomes will help reduce variability, but will also help understand what truly matters to patients and make sure that the intervention being made are important to reach these individual goals, and thereby hopefully, or most certainly, I'm certain, we will be able to shift the whole curve from healthcare to health and spend much more of our funding on prevention, because today we spend far too little on prevention and much more on the chronic care. So I would say that health outcomes, they are the ultimate opportunity for all stakeholders around the patient to truly make a difference and work together to achieve high value care and health. So focus on health outcomes is, to me, the true north to restore healthcare to its purpose, which is health. Because to prevent conditions from appearing in the first place is important. Today, we have a bit of wait to break and fix and get paid. So we pay for sick care, and we should shift focus to instead predict, prevent, and improve patient health outcomes, to really talk about healthcare in the long term, talk about health and move it to health, because resources spent on disease prevention and on health promotion today is only around 3% of the total health budgets in the OECD countries. And reducing the waste in the system, as well as reducing the need for more care, will make more resources available for prevention. And that are also many studies showing that this will really generate a very good return on investment. So despite different health systems and ways to finance them, we need to focus incentives on the outcomes, not on the services performed and not on the reduction of cost. So as a reminder, health outcomes, not the services performed, are the numerator of the value equation, and the outcomes need to improve to create value. Because if the health outcomes are not being improved, you have zero in the value equation. And it doesn't matter how much or how little you spend, because the value will still be zero. So the health outcomes are the numerator of the value equation and the piece to start with. And in the value framework, as you also see here, the relevant cost, of course, needs to be, the relevant cost of delivering those outcomes, of course, needs to be calculated as well. And the relevant cost here is the total cost of all inputs. And that's both clinical and administrative. And that's also during a patient's full cycle of care. So if we, for example, take the cost of treating a patient with type 2 diabetes, that must include not only cost associated with endocrinological care, but also the cost of managing and treating associated conditions and complications. We can talk about vascular, retinal, renal, all these different type of complications, in addition to the cost of the services in the primary care. And it might also be that it's also possible, I would say, to integrate social costs related to sick leave and societal costs relating from lack of autonomy. So it can become more and more advanced to really understand that value always starts with the individual value, because if an individual can achieve as much health as possible, the individual will also be as independent as possible, and therefore also this will bring value to our whole society. So if to start to summarize this introduction here, if basing what we measure on what truly matters to patients, then every stakeholder in the system will be empowered to generate high value care, and better health and stronger health systems will be the results of this. And you can see examples on the right side of this slide. We have talked about the clinician's perspective, where these health outcomes will help improve quality of care by comparing performance and sharing, being transparent and learning from each other. That also means, and we have seen that happening, that hospitals will differentiate into areas where their outcomes are superior and they can deliver superior value. And we see then new configurations of care becoming established which might house multiple professionals with advanced skills working in teams, supported by digital technology to enable a seamless coordination of care, and proactively engaged in preventive care as well, and tailored to the needs, of course, of the individuals in the population being served. This also means that life science, pharma, medtech, everyone involved in innovations from the life science industry will be able to market the products or services on value, showing improved outcomes, as we discussed, relative to cost. And for payers, it will become an opportunity to negotiate contracts based on the results achieved and not the volume produced, and encourage innovation to really achieve those results. And most certainly, that where we started, and most importantly thereby, patients will be at the center in what we have discussed here as a shared decision-making, and in also long-term being able to choose a provider based on where their expected outcomes could be achieved at the relevant cost, and thereby value being created to each individual and to the society. So understanding the preferences of patients will help healthcare teams to suggest relevant alternatives to reach the goal of each individual. So via involving patients in defining and in reporting the health outcomes that matter to them the most, that will contribute to ensure high value care, better health and stronger health systems, but also to help build an innovative business and the right innovations to be brought to the market. So this is a very central transformation needed for healthcare, to move from sick care to healthcare and to health. And in summary, we need to start with the end results, with the health outcomes that matter most to patients, and then make sure that the reward system, the payment models are focused and the incentives are set to reward the outcomes achieved and not the inputs or the compliance as we mostly do today. And when the focus is redirected to outcomes, when this happens, and the rewards and incentives are directed also towards these outcomes, we see what happens is that this influences the culture, because to be able to deliver the health outcomes that matter most to patients, and knowing that we will be reimbursed and paid for them, that generates new ways of working together in an integrated and much more solution-oriented manner. And these are multiple examples from organizations moving in this direction. But of course, the transformation is still ongoing, and there is a lot of work to do and challenges to overcome in making this the new normal. But these 3 steps and are also the cornerstones of the EIT Health Handbook for Pioneers, which is a handbook created to give a framework to support implementation and make it as practical as possible, encouraging to help individuals also in this transformation to come together and create a network and a community. And therefore, the handbook contains an implementation roadmap, which is built on experience from leaders who have made substantial progress on their journey towards high-value care. And the roadmap describes the implementation step by step, and the implementation matrix is made up of 9 building blocks. And you will see that they all are related to the outcomes, incentives, and culture that I was talking on before. So if we start with the condition, we have already discussed, it's across a condition, a segment of patients, the full cycle of care. Then it's important to create a scorecard, which we also discussed. There are examples of ongoing work towards create the basic global language on this. And of course, to find the way of capturing it, to get interoperability from an informatics perspective, to be able to compare and share. And after that, there is also the importance of becoming transparent and sharing the outcomes with each other and create the communities of learning. Sorry, I think there. Now I hope that came up here. So, and then so here we have 5 out of the 9 building blocks related to the outcomes perspective. And then moving into the reward systems and incentives. That's the financial perspectives of the investments needed to be done and the incentives to be put up both internally and externally with the payment models in place. And last but not least, this will influence the culture internally when we set one goal for everyone related to what matters most to this patient segment and each individual in it, and then also to create external collaborations between providers, payers, life science industry as an example, and academy as well. So this is a handbook that is a start of trying to take the theoretical framework into more of a how-to way of working, with the hope of creating more of networks and communities. And which I think that is very similar to what Health Cluster Portugal has done in Portugal in an excellent way. And here EIT Health is excited about trying to bring more and more on a European level together. And the handbook is part of what EIT Health has started as a new initiative in the second half of last year, which is the EIT Health High Value Care Forum mentioned in the beginning by Miguel. And the forum has been launched to support the transformation to high value care and to health. And the aims of the forum are to co-create and fund transformation projects via bringing together citizens and patients, providers, payers, life science industry, and to share best practices also through education and sharing between organizations, and creating these next steps of how to and communities and networks. And EIT Health is currently in the final phase of its high value care pilot call part. And as chair of the advisory board to the forum, I am excited to see the first call for projects and the great potential that these projects being exposed there and applying in this round hold for being part of a community of learning and sharing towards high value care and restoring healthcare to its purpose, which we have discussed is health. And this transformation to high value care and healthcare is central. And that includes an early and continued involvement of citizens and patients to understand the unmet needs, to understand what truly matters. And this is the centerpiece to be able to make societal impact towards what we discussed as we really need better health. We need stronger health systems, and we of course need a strong health business. And all these are the goals of EIT Health. So with this last slide, I would like to thank you very much for the invitation, and I'm very much looking forward to listening to the presentations to come here, and because this will discuss this important transformation and also the experience of implementation, and I'm sure the challenges in implementing in more detail. And it's very exciting to me to see the work that's being done in Portugal and via Health Cluster Portugal as a front runner in this field. So thanks once again for the invitation, and looking forward to discussion and to the coming presentations.
Thank you, Christina. This was an amazing overview and introduction to this topic for the people that were into this topic, and probably a quite alignment of what matters most for those that are yet working on here. So we have quite of questions here from the audience. So I'll start from those. Let me just pick here from the Q&A first one. This is from Sandra Paz de Lucas. This is probably a more tech and a tech question, but the question that she poses is which tool are placed to achieve these patient health outcomes, and in some way is there is development on tools that not only track and allow to review things on the clinic, but also to support, for instance, patients at home. So probably here, how the technology is important to achieve both the definition of what is the outcomes, to measure them, and actually to accomplish them beyond what is already being used.
Yes. Yeah, I can try answering it. I mean, I take it as you say, which tool are used here to take this. And I think that when this started, before the current pandemic, it was very much about patients coming to their visit. They could either report their visit digitally before their visit from home. So it shows up together with the clinical results in the consultation room, or they were even, I mean, if they didn't do it, they could achieve a tablet coming into the waiting room and responding there. So it was updated for the consultation. But I also believe that more and more is now moving into apps and everything that you can use on a regular basis. And I think that probably the current pandemic has pushed in this direction as well, that a lot of things has been digitalized. And there are also examples even before the pandemic of this type of measurements done from home over years for patients with chronic conditions. I have examples from my home country, Sweden. You probably have many other examples where patients continuously report patient-reported outcomes, and thereby can also be contacted by the healthcare system if their symptoms are worsening or if things are moving on in a good way, they might not have to come in for a regular visit, but it could be a longer time between the visits. So I don't know if that answers Sandra's question, but I think there are many different ways of doing it. And but the digital perspective is, of course, I mean, we are moving away from the very early start. I remember when I was at iChon, we worked at the time with paper and pen, and that's also possible to do. But I think that mostly now it's done digitally to make sure that it's really up to speed and possible to act on.
Yeah, probably continue on this topic, picking a little on actually in the Rita question. That's this point of the burden of the tools to measure patient-reported outcomes, the burden of asking the patient to fill a lot of questions, and then in the end, the challenge of engaging them and avoiding dropouts in the end, because I think the main issue on healthcare is actually having patients engaging with their own health. It's not just because you have the pill for diabetes that someone will probably take that pill, or if healthy diets and so on. So how can you do the same with patients? Because probably they don't see the value directly when they provide feedback or report on outcomes. So how this challenge of keeping them engaged, making sure that they participate on their own health definition in the end, but it's not probably something that is so immediate like other things.
Yeah, I mean, my general perspective, I completely agree on that it could be a burden. And that was something I saw at iChon when we started to defining more and more conditions, that if you have a battery of questionnaires for one condition, and then you acquire 3 or 4 chronic conditions and maybe an episodic condition as well, growing older, then you might have to answer very, very many questionnaires, which is not doable, of course. So that's why we started working with defining segments of patients like older persons and defining a minimal number of outcomes that are relevant across conditions that are common in when you become older. And that's where the work then expanded to become for adult and is now also into, if I understand right, pediatric. So what I see is that you create more of a life pathway than a care pathway, because you have certain outcomes that are important to follow through life, which you can start with early in life and follow through adult and up to older, which is of course a segment of adult. And then once you acquire a condition, episodic or chronic, you can add relevant questions for that specific condition, because this is a way to really make sure that you keep the questions at the minimal number, as few as possible. And that was the work at iChon was also focused on, really trying to understand what's important from a clinical and patient perspective to get the information necessary, and then make a layer cake out of that. So you have a number of basic questions and you add on. And there are also initiatives, as you are aware of, the PROMISE initiative from US, etc., which works with more like a decision tree. So if you answer no to a question, you will not get a certain number of other questions. But if you answer yes, you will have follow-up questions to this one, etc. So I think there is a lot of development in this field to manage to make this happen. And then from the second part, if I understand the question, and because I haven't had time to read all of them, but you're summarizing them well, Miguel. So if I understand what was the second part is, I think that the most important part we can do to make individuals engaged is to make sure that they actually receive a response on what they put in. Because if you only put a lot of questionnaires out and then you come to a consultation and no one is bothering about it, I mean, why should I answer next time? It's like putting something into a black hole. So it needs to be centered around this information to really be discussed what the patient has reported And that's what I see in successful transformation, that people being involved in this, they focus the discussion, the consultation between the patient and the healthcare team on what you actually find in these combined patient and clinically reported outcomes, and also try to really define what matters most to you, because you might have several options of treatment. And for someone, it might be very important to live an extra couple of months if we are talking about a very severe condition in a late stage, at a lower quality of life. But for others, it might be more important to really have as high quality as possible of life during maybe a shorter period of time. And if we take a very simple example, if I'm a downhill skier or a gardener, I probably have very, very different expectations if I have a hip or knee osteoarthritis on what matters to me. So I think that by putting these relations in place, then I think that you can have this much more informed discussion and engagement, and not talking about ownership of your disease, but actually acceptance of the type of conditions we all acquire over life, and how can we make most out of it as individuals. That's the capability, comfort, and calm. And that needs to be the center of our discussion. And then I think you will see much more of interest in also being part of taking care of the health and try to prevent things from happening. Because I think we are not good at that in many cases. And that's why it's also important for innovation to focus on this. What are the true unmet needs that are important? And how can I innovate around this and make that and fill that unmet need for individuals and thereby for society? Okay. So long answer, but I hope I got.
No, I think it's a good answer, and we'll have actually now the next speaker that can bring a little bit on light. We have some questions here that probably we can try to reply in the end, because probably they can apply to all the speakers, but I pass to Patricia to introduce our next speaker.
I saw something about patient-reported experience measures. And
yeah, we can probably try to reply on the end if you have some time, just to not delay further the agenda. Thank you, Christina, again. So Patricia, to you.
Thank you, Christina, for the nice presentation and for the questions from the audience. So it's my pleasure to introduce now Ana Rita Londral, the Director of Value for Health CoLab. Ana Rita's background is electrical and computer engineering. She holds a master's degree in health engineering and a PhD in biomedical sciences. She has 20 years experience in working in R&D activities with companies, academia, and patients associations for the development of innovative health technologies, as also support the digital transformation in healthcare. She lectured several disciplines in universities, from assistive technologies to computer programming and machine learning, and has been involved in national and international R&D projects. As the Executive and Scientific Director of Value for Health CoLab, she is developing interdisciplinary research in e-health and value-based healthcare in close collaboration with Nova University research units, Frauno for Portugal, COF, and Vodafone Portugal. She will be now presenting a case study from the Value for Health CoLab. And so once again, thank you very much, Anna, and I invite you to start your presentation.
Thank you, Patricia. Can you see the presentation?
Yes.
Yes.
Okay. So thank you for the long description. But in resume, I'm now the director of this CoLab, Value for Health CoLab, which is a CoLab that has been created in 2019 by these founding partners, Nova University, COF, which is one of the main private hospital groups in Portugal, Fraunhofer Portugal and Vodafone Portugal. And this CoLab has the mission to support organizations in measuring value in health. So we started in 2019, and we started with a mission to, well, we want to go to the real context and try to implement pilots that will push for value assessment. So digital health is a strong topic in our collab, because to measure outcomes, we need to measure and to analyze outcomes, we need the digital tools. So we are a team with different skills, many of them in engineering, because of this topic of analyzing and measuring and collecting outcomes. And in all projects that we are doing, we are working with clinical teams, trying to assess this high value interventions in the real life context. So today I will talk to you about a case study that actually this was the case study that launched the collab. So we were starting in 2019, and we joined the founding partners, and they suggested us to start with the cardiac surgery, because the president of collab is a cardiac surgeon. So he said, okay, you can come to my service. We had IoT equipment from Fraunhofer, and a very good app to collect outcomes. Vodafone was also with us. So we had a context that took us to build this case study in cardiac surgery follow-up. So we wanted to implement a telemonitoring service. We started this green timeline is the pilot study that I will show here today. The results of this pilot study with 35 patients. We started in October 2019, and now we are moving to scale up this pilot to a bigger clinical trial. But first, I will show you a video that we did to summarize our pilot study, and I think this will be a good launch to explain better the results afterwards.
Meet Mr. Carlos. He's a senior citizen who lives in the countryside. One day, after a strong chest pain and difficulty breathing, Mr. Carlos was taken to Santa Marta Hospital in Lisbon, where he underwent high-risk surgery. After a week, physicians considered his health progress and COVID-19 infection risk and decided that returning home was the safest option. However, the risk of post-operative complications was higher than 30%, so they needed a way to monitor him from home. VOH Collab provided the solution, an IoT kit for Mr. Carlos. Every day, he measured his blood pressure, weight, and step count. He would also send a picture of the wound and answer self-reported outcomes. Mr. Carlos felt safe because doctors were monitoring his outcomes. He also felt empowered and engaged in his own recovery, while post-operative complications and overall costs were successfully tackled. Good for Mr. Carlos, good for everyone.
Okay, so this was the project that I will start explaining the details. So when we started, we characterized the standard procedure. So we went to speak to the clinical team and asked them, what do you think about implementing a new telemonitoring service? They told us how they used to do. So the red bullet is the patient discharge of the hospital. So after the cardiac surgery, the patient is discharged, goes home. After 3 days, the nurse calls, and after 1 month, the nurse calls. 3 months, 6 months, and 12 months. So this is a clinical team that is already collecting outcomes, quality of life, symptoms, daily living, aspects related to daily living. So they collect outcomes for 1 year. And this is very valuable. It's very relevant. They have that database with from 10 years ago, so they are collecting for 10 years already. And the clinical team told us, okay, the most critical period after the surgery is the first 30 days. So we need, in those 30 days, there are lots of critical incidents. That means complications that are related then to readmissions or even to new surgery, which is the worst scenario. So this period is the most critical period. So this would be an opportunity to improve this in this period. So we started with the clinical team to map a new process for telemonitoring. This means that we didn't want to make a disruption in the service that wouldn't work out. So we discussed a lot with them how this could work. So, and we decided that we together with the clinical team, of course, decided that it would work in a daily process. So every day the patient would measure outcomes from home, and once a day and the measures should arrive to the hospital before midday, because this is related to the nursing team procedures workflow. So we detailed how this service would be implemented. Our goal would be to engage and support patients in their recovery, measure outcomes that matter, and deliver in real time to patients and clinical team, integrate data to improve follow-up service and collect costs. So we started to work with patients. So this left picture, as Mr. Nunes was our, we say it's our patient zero. So he was very enthusiastic about technology. So nurses chose him to be the first patient to test the equipment and give us feedback. Then we worked with the nurses in the middle picture to see how they would like to see the data to be useful for them. And on the right is the final solution, which is an app to see the data, where to manage patients, and the IoT kit. So the first remark is that we need to support patient literacy to enable patients to collect outcomes, or to report outcomes. So in this patient, with all the patients, we were when we delivered the IoT kit in the day of the hospital discharge, we were with a nurse and one of us teaching the patient for nearly 30 minutes. He tested the equipment, we explained, the nurse reinforced. So this was a 30-minute session of literacy that engaged the patient and really improved. I believe that this was critical to improve the results of the telemonitoring at home, from home. So our service was, our equipment was like this. We had a weight, blood pressure, and smartwatch, an app, a really nice app built by Fraunhofer, Portugal. The clinical team defined 6 questions that were related to symptoms reporting that were most important for in the perspective of the clinical team for the patients in that period. And we added a chatbot to exchange messages of reinforcement, education, and to the patient would take a picture and send to the nurses. So this was the scheme, and Vodafone ensured the digital connection. Then from the side of the hospital, we developed this tool to see the outcomes, as I was saying in the previous slide. And another remark is that outcomes collection is not enough to improve healthcare services. And in fact, we had to do this effort to understand how would nurses really use this data in their healthcare work. So this was a co-creation project. We sat at the table many times. We asked them what they would think of a new thing in the app. And so this was very discussed between the clinical team and the development team. And on the right, you can also see, in the middle, you can see the scars and the graphs that we agreed that would be okay. On the left, it's the alerts. And on the right, you can see some of the patient-reported outcomes during the 30 days. So on the top, we see one patient, the report of one patient that for the approximately 15 days had a slight pain, and at the end reported no pain. And below, it's about the efforts, ability to do efforts. So we can see here that during 30 days, he had improved maybe after 1 week. So these kinds of outcomes we discussed a lot with the nurses and the surgeons. How would this outcomes information would be useful for treatment? So we did a pilot study with 35 patients. We started with a team with 2 surgeons and 3 nurses. Then the 24 nurses, at the end, they were already enrolled in the telemonitoring platform. So they started using. We generated many actions and many extra phone calls from the telemonitoring. So this telemonitoring service generated more human service. That's relevant for the discussion. And we observed that when comparing these 35 patients that were telemonitored to a similar group of patients that were not telemonitored, there was a significant reduction in critical incidents. So we proved that in this small sample, in fact, this telemonitoring reduced critical incidents. Concerning the experience, at the end of after the 30 days, patient would go to the hospital and had to have a clinical appointment and deliver the kit. And then we had an interview with the patients to assess their experience. We used the Net Promoter Score, which is a high, and we collected, more important, many experiences. I felt at the hospital and I was being followed by all of them. One of the patients said, well, I was thinking that when I get there, I'm going to have a surprise and they will give me one of this. So some patients got very engaged with the technology, with the smartwatch, and they were very enthusiastic about that. And there's also a very nice description that a patient was saying, it's like a friend that we don't see, but that is there with us every day. So patients mainly experience the feeling safe, feeling monitored. So was not about much about technology, but it was about being connected to the hospital. It was their experience. So in the equation of value, we have patients felt safer or felt safe, high patient satisfaction. So they were very satisfied with the, I forgot to say that we had just in 35, we just got one dropout. So one young patient who said she didn't want to use it anymore. And this was related to other problems that she had. And so we had high satisfaction and reduced critical incidents. So these would be the outcomes that we measured from this pilot. But we wanted to measure also the costs. So what are the costs of this telemonitoring service? So we started doing this cost analysis. So to compute the euros per minute cost of the resource used during the healthcare intervention, we used the time-driven activity-based costing, which is a methodology that is used in value-based healthcare approaches, and it was firstly suggested by Kaplan. So we used it with this methodology. First, we developed the process, incorporated the direct resources, and computed the times, because this is how the method works, the method of Tdavc. Then we estimated the average time that the patient is actually in each resource, and calculated the capacity cost rates. So the process maps I already showed you, and then we did the identification of resources, mainly human resources, equipment, technology, consumables, and space used by the patient. And just a note, here we are referring only to the follow-up process, not the surgery process. It's just after the patient is discharged, how are human resources used, equipment and technology, consumables, and space. We estimate the cost of supplying patient care resources, calculate the capacity cost rate, and finally the total cost per patient. Our model we have a model that allows to compute the total cost, and with this model we computed the time that a patient is being monitored during the follow-up. So this is the standard follow-up. We use patient is during the 30 days after discharge, patient is being monitored for this amount of minutes, and the most dedicated resource is the nurse team. And in the telemonitoring, we have a much higher amount of time that the hospital dedicates to the patient, and the most most dedicated resource is also the nurse. So we are using a lot of nurse resources here. In costs, we assessed the costs, and we are for assessing these costs, we are considering a patient that doesn't have complications. So it's a very standard patient without any complications, to simplify for this initial explorative study. And then, so we see that the difference between being telemonitored or not being telemonitored is these 200 euros per patient. And we can see that the main cost difference is in human resources. So in fact, because the telemonitoring is monitoring the patient daily, and the nurse daily has to assess the patient and may have to do more actions related to that daily monitoring, we are using much more time of the nurse team and the surgeon, but indirectly, than without in the telemonitoring, than comparing with the standard follow-up that is based on phone calls and not so regular. So lessons learned from the Tdavc implementation, it's real. This cost implementation needs a high investment to engage hospital administration and clinical teams to give us the elements. We need to understand the IT infrastructure and the accounting methods to take the information that we need to do to implement the methods. And sometimes the semantics in this translation between IT infrastructure and accounting methods and the methodology that we want to implement, in this case the Tdavc, is not the same. So some lessons learned, we took some lessons from this. I'm sure the next time it will be simpler, but in fact the Tdavc has some issues to implement, and that's why it's not being so much implemented as maybe should be. But we were very happy to be doing this experiment of having this equation of value. Of course, this is not a mathematical equation. it's more a conceptual equation where we have in the numerator, patients feel safe, high patient satisfaction, reduced clinical incidence, and we could, with the telemonitoring, we could allow an extra of 8 hours of attention per patient during the 30 days after patient discharge. So the patient has higher attention from the hospital, and this with an extra cost of nearly 200 euros. Of course, we are, again, just to stress that we are considering patients that are very standard with no clinical incidents. We simplified a lot this case, but this is a start, and we'll move on. But I think it's very interesting to understand how the innovation, the digital innovation in a service is influencing the outcomes, and also how much does it cost. For the next steps, we are scaling up. We want to engage patients to co-develop personalized reporting, because they told us, every day I answer them the same questions. Why? Because I already said I'm not tired. So why do I have to say that I'm not tired again and again? So we are now developing personalized reporting. We are extending the digital telemonitoring period, because doctors understand that maybe it's worth to try to see the benefits of extending it. We must do risk certification. We really must do it to make this more robust and real, and to quantify the cost of critical incidents. And we are already using artificial intelligence to analyze those outcomes from the 10 years and understand which patients would benefit more of this telemonitoring service. This is our team in the collab, so we are all very engaged in this project, and this was our first flagship project, where we wanted to really exercise to measure outcomes and measure costs and build the conceptual equation. And that's it. Thank you.
Thank you, Ana Rita. So since we are already going late in the schedule, we'll move directly to João, and then we have some of the questions to both of you in the end. Quickly introduce João Bana. He's probably one of the experts in the multi-criteria method in Portugal, and at least in the world he is. Let's see how he's in Portugal, but he's been using for several years these methods to support decision making, and it's really easy on defining what is value when you know what you need, what you're looking for. So we invited here João to bring a little bit the work that he's doing on Decision Eyes, a company that focuses on providing the tools to use these methods to elucidate what are the patient preference, because it's not sometimes enough just to ask them, to talk with them. You need to go a little bit deeper to understand what really people value, what patients value. So going directly to you, João, show us a little bit how you're using methods and tools to make a little bit more objective analysis of this.
Okay, thank you so much, first of all, for inviting me, and thank you everyone for staying all the way to the end and spend this extra 15 minutes with me. I hope it's worth it. Please let me know if you can see my screen and the proper presentation.
The presentation is on the presenter's mode and not the...
Okay, what about now?
Now it's fine.
Thank you.
Thank you. So I'm going to talk about patient preference elicitation. So what we want to achieve is to try to somehow transform whichever is inside people's minds into mathematical models. So as you can understand, it's not at all obvious. And so the problem was already well mentioned. We have to put patients in the center of our decision-making in health, but also to speed up drug development. We cannot keep on spending so much time developing drugs and making them available for the people who needs those drugs. So once we understand that we want to put patients in the center of all this, we have a second problem, which is how to capture patients' preferences. So first of all, which outcomes do you want to use for a given study? Which outcomes matter the most for each participant, for each patient? And then which improvements matter the most in each outcome? And all three problems are distinct. And the funny thing is, we have a literature, we have a science called decision analysis, which has been around for quite some time, but it strikes me that still at this point, we see little knowledge within the health community about the decision analysis, about multiple criteria decision analysis, and all the sciences that try to measure value, which is something that it's way beyond 15 minutes talk. But what I try to do what we try to do at Decisionize is to make this process easier, to make this implementation of these methods that are needed much easier and faster. So the challenge is we need a process-driven, easy to use wizard-like method that enables the use of qualitative data, which is one of the biggest problems because some methods out there being used, for example, Qualis and the ones we all know, do not cope very well with qualitative data. And sometimes we leave some important outcomes out of the equation just because we are unable to measure them, unable to transform those measures into something which is useful to make decisions. So we need, of course, to include multiple perspectives. We are talking about patients, but in fact, we want to include everyone. The thing is, of course, most of the other stakeholders were being consulted already, which was not the case with patients. And of course, we want to have a cross-disease methodology that can be used across multiple diseases and contexts. And of course, like I said, we want to be able to make this speedy enough so that people don't drop out during these questionnaires, during the application of these methodologies. So in summary, we want to transform preferences, being that clinicians, payers, nurses, or what matters most at this point in time, the patients, to make them the center of this. We want to transform those preferences into value. And that's quite hard to do. We have come up with two different methods that I will show you, or not methods, but tools. There are methods behind it. The first one is the Wealthy platform, which implements the Delphi method. I'll talk about that a little bit. And then the Wisdom platform, which implements the Macbeth method, an MCDA method. So with both, we can achieve what is needed for proper value measurement, which is which outcomes, in each outcome, what are the value functions that enables us to transform levels into values, and then the weighting part, which of course is very important to understand which outcomes are more or less important for each participant, for each patient, or for each group of patients. So the Wealthy platform was a platform that we have created precisely because on one of our first projects, we were called by the European Medicines Agency, and the first thing they delivered us was a list of outcome indicators. As you can see here, we had benefits and risks. Inside the benefits, and of course, this is for multiple sclerosis, So we had some benefits, which were the number of relapses in the next 5 years, the time to disease progression, the disease progression itself. And then on the risk side, the number of deaths due to leukemia, PML, or liver failure. And of course, the first thing we asked was, well, but who came up with this list? Why this list and not another different list if we don't know yet who the patients are? And because of this, we came up with the use of the Tdavc method, using this platform that we later developed, where the first task was just to ask our participants, our patients, look at this list, tell us if you think something shouldn't be there, and tell us if something is missing. And for example, just by clicking the Add Outcome button, they would be able to add an extra item to this list. So the second round of this process was to use, in this case, a Likert scale, but several different scales can be used. In this case, a Likert scale ranging from totally agree to totally disagree, where people would answer the question if each outcome indicator should be used for the treatment of a specific disease, in this case, of course, multiple sclerosis. And so people would say something like, I totally agree with the use of the number of relapses. On the other hand, I disagree with the use of the number of deaths due to PML for this context. And the funny part comes after this, because you can ask these questions and then go on and do some statistical analysis on it. But if you deliver all the results anonymously to all patients and ask the same question again, then this starts to make some sense. So for example, in this screen, you can see that this participant on the first round said that he would totally agree with the use of the number of relapses. And so did 30% of people, but 40% of people said agree, 10% of people said neither agree nor disagree, and 20% said I disagree. So based upon this information, but also the explanations, the comments that participants gave about each one of these outcomes, each person was able to change or not, it was not mandatory, of course, change his or her mind. And this could be done, of course, in 1, 2, 3, 4, 5 rounds, you name it. So this was a platform we have created just for this sake, but it is now being used all over the world, from Australia to the US, passing on Europe, of course, where lots of companies are using the Tdavc method in an easier way, because most of this is done automatically, to try to understand in an initial state why this indicator should be used if there's something missing to this list. So as simple as this. Of course, this is not enough for value measurement. This is just a list of outcomes. Then we need something else. We need to dig deeper into decision analysis to understand how we can get proper information so that drug development is more tailored to what people need. And so here we are using Macbeth, which is an MCDA method. And the way we do this, we are focusing here on one of the criteria, for example, the number of relapses. And you can see that we have a list of outcome levels. So you can have 0 relapses in the next 5 years, 1, 2, 3, or 4. Now, what is important to understand is this question. What is the difference in preference between the two levels below? Having 0 relapses in the next 5 years or having 4 relapses in the next 5 years, which is completely different from asking what is the value of a relapse. Because if I click next, the next question is, what is the difference between having 1 relapse and having 4? And the answer doesn't have to be the same. By using the Macbeth method, as you can see at the bottom, the answer has to be one of these value judgments: very weak, weak, moderate, strong, very strong, or extreme. We wanted to take out the burden from people of having to provide an answer using a score. And so they only provide answers with a qualitative judgment. And what we are trying to achieve is to understand if really 1 relapse has the same meaning across all the spectrum, ranging from not having any relapse or when you have 4 relapses already. And so we did this once. We did this first with 60 patients, then with 100, then with 200 across different studies. The first one was for the European Medicines Agency, and the other ones were within the industry in top 5 pharma companies. One of them was using a mobile phone. So people would take this with them home and would answer the same questions across the clinical trial where they were taking one drug. But what we are trying to achieve and eventually changed my life was this chart. So as you can see here, for one person, but this eventually happened for a group of people, you see on the x-axis the number of relapses ranging from 0 to 4. On your left-hand side, on the y-axis, you see the score. So as you can see here, moving from 0 to 1 relapse leads to a huge decrease in the score, whereas moving from 3 to 4 relapses is just a small decrease on the score. So what does this mean? That people care much more about the reduction of one relapse when they have one, much more than when they have 4 reducing to 3. Now, what happened with this study was that I got a call from the lead researcher at EMA saying, look, João, we have a problem, the results are not correct. And I said, what do you mean the results are not correct? Well, clinicians say it's the other way around. It should not be like this, but the other way around, because what this means is that after a while, after having several relapses, patients start to just, they don't care anymore about another relapse. And this is not the way we feel at the agency and the clinicians report. And of course, my answer was, well, I have some 100 folks saying otherwise. Now what? Well, we have to dig deeper then. We have, first of all, we should be doing this more often. This was 5 years ago, and unfortunately, I don't see this widespread use of these technologies, methodologies to ask people what they think. And so when we dig deeper, what we achieve is not only I can get for each individual participant their feelings towards this criterion, this outcome indicated, but also for the group, which means that I am able not only to tailor a drug for a person, but also to a group. I am able to, in a very early stage of drug development, I am able to know what matters for the people that ultimately will take those drugs. And so this was just for one outcome. And of course, we have the stats for the for all the participants. You can see that 38% of them said the value function should be convex. So the one I was showing you, some of them, but only 24% said it was linear. So most methodologies out there always use linear value functions. Why? Just because the method cannot cope with something different, when in fact, only 1/4 of people thinks, in this case, for example, it should be linear. And so what about the remaining criteria? Well, we did this for all the criteria, and we did something even more important, which are the weights. We need to understand what matters most in terms of criteria for the evaluation. So in this case, our outcomes. And what happened again was something quite different from what doctors expected. 55% of people said what matters most is disease progression, is to be able to walk instead of being bedridden. That's way more important than a reduction of 10% or 100% in the number of deaths due to liver failure. And this is something doctors had a difficult time coping with. Of course, when you see 1.8% importance for the number of deaths due to liver failure, that's quite impressive when compared to what people said. We rather walk in this case, which was the meaning of disease progression, even if that means I have maybe one less year to live in an extreme case, of course. And so with all this information, we are able to create models on the cloud, which are able to answer this question: what people want, and would people prefer drug A over drug B? And the latest project that we did, just to finish up, was a project where we have a molecule that we think can be transformed into a drug. But first, we need to understand if we are tackling the right problem. what this new drug brings to the table, is it what matters to people? And this is where we stand, and we are very hopeful that more and more people use these kind of methodologies to put patients on the center and lead drug development towards a patient-centric approach. Thank you so much.
Thank you, João. This is quite going from what matters most to how can you quantify that. In the end, a good start line going through a quite practical case on the challenge on the fields, and probably the question I want to bring to you is a little bit of this sense on the practical field. How difficult is actually for people to understand when the outcomes or the values or the numbers do not go on the direction of what they think, their perception, their common sense? How difficult it is to manage these kind of things? Because probably outcomes are quite nice when you agree with them, when something that you personally agree, but when you need to go through the numbers, and the numbers probably show it different way, how can you manage that? How difficult it is to manage that part?
You know, I think the biggest struggle is, even before that, is on the heart of what Christina said. We need to make people understand that we need to have patients on the center. And the problem is, sometimes from my experience, not even patients want to be at the center. And we had a case, for example, where we asked the patient to talk to some clinicians about the disease. And the first answer we got was, what do you mean? Those are the doctors that did the clinical trials. That guy is the doctor that is treating me. How am I going to be the patient saying what I feel about this? I'll do whatever they say I have to do to treat my disease. Once that happened, we really pushed hard so that she would let us know, and the doctors know, what was important for her. And once she started talking about outcomes and real outcome levels, it was quite amazing that doctors embraced it quite easily. But of course, we had those people right there on a room. And so we have to really promote that, or even online, but we have to overcome that step. If we do that, then it gets much easier if people are aboard, if people are willing to participate, and if people are willing to accept the results, then it's quite easier using the methodologies that are out there. I mean, decision analysis is out there like since the 70s, being used across all industries. Why can't health use it as well? But yeah, we still have some difficulties along the way. That's for sure. But I think we are getting there, and I think more and more both sides understand that this is the way forward.
Okay. So thank you, João. So unfortunately, and because we're running a little bit behind schedule today, we won't be able to ask all the questions to the speakers. But before we close, I'd like to address one question to Anna, to whom I'd like to thank first for sharing that very interesting and truly multidisciplinary work that the CoLab has been developing. So Anna, you mentioned that one of the next steps of this work would be to scale up the project. But I mean, after all this is said, and if the results are positive, which they expectably will be, how do you see this actually coming to daylight, so to the real world? Because we see that this kind of initiatives that you're trying to put forward actually bring value to patients. So, but we need to put them forward, and actually to bring this to the healthcare systems. How do you foresee this in the real world, and what are the major barriers and bottlenecks for this implementation?
well, there are lots of ways. There is not one strict answer, but what I hope to do is to highlight, for example, in this telemonitoring, often we hear that oh, using technology is too expensive for the hospitals. They won't afford it. And if we do this exercise of doing the costing of demonstrating how much does it cost, I believe that this will break barriers that are there just because we don't measure and we don't observe things, like João was saying, that when we start asking and measuring, we can see things that we didn't see before, and this supports decisions. Concerning this project in cardiac surgery, we are now doing a movement for the market. So we are trying to make this solution available to the market. But I would say that the solution has already a demonstration of value. And maybe if we do it if we practice more this often, so to demonstrate, to do things properly with a method to demonstrate value, it will happen. That's I hope so.
Yeah, so I totally agree. So we need more of these good examples so that others can come and do the same. So thank you very much. Just wanted to share my screen to finish and close this webinar. So thank you to all the speakers and attendees of this webinar. Hope you've enjoyed this session. And for those who might have got curious about the value-based healthcare work that is being promoted by the Health Cluster Portugal, as mentioned, you may drop us a line in the comments box of the satisfaction survey, and we'll be happy to share the first report of this work. And you may also check the results presentation session in the Health Cluster Portugal YouTube channel. So for the next week, we'll have a webinar dedicated to cybersecurity and blockchain in the health sector. So if you haven't done it already, you may sign up and join us. You can use the QR code on the screen to check for the upcoming webinars of this series and the sign up form. And you can follow us through the Health Cluster Portugal LinkedIn or Twitter account. So thank you very much once again, and have a nice week. Goodbye.